Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. Another video yet about lawsuits and regulatory stuff and how to avoid all that nasty stuff. Ortho is fun, except for this part. This part is not fun. So the goal is to not ever have this happen. But if you do a lot of ortho, it will happen. It's not a question of if, but when. So the goal is every single case and to set up your system so that if and when it happens, which it will, you are 100% prepared, like I was the times it happened to me, and it was just like, rub it off. A big pain in my booty, a big pain in my headache, but I knew I was not gonna lose. It was impossible because I knew I did everything right, including paperwork, everything. I had nothing in my gut that told me I was gonna get myself in trouble, and it all worked out. But that's how I teach you guys, and I try to stay on top of everything. But again, as always, in all my other regulatory and lawsuit kind of stuff, I'm not an attorney. So talk to your own malpractice insurance as well as talk to your own attorney. Remember, dental practice acts are different in every state, every country. You have to follow yours. You have to know yours. It's not my job to know yours. So, okay, so now we're going to get on to impactions. Impactions and root resorption. I'm going to put that all in one thing. So whether it doesn't matter if it's braces or aligners, I mean, it's all the same, right? At this point. So very top. It's up there with perio, like top reasons for regulatory board complaints or lawsuits or insurance complaints. It's all the same. So how do you avoid that? Well, same thing as I said with perio. If there's a risk before you start, or if something presents before you start, you better tell them. I see that your upper rep 4 already has a blunted root, or I see that 7, 8, 9, 10, or upper 2 to 2 already have tapered and blunted roots. Did you have previous trauma? Did you have previous endo? Did you have previous ortho? You know, get all the scoops. And if they don't know what caused it, oh well, you know, just document it. And as always, if something is like EBGB more than just a little, send them to endo. Send them to endo. They're not going to want to go, but guess what? You get to send them to endo anyways, because that is the only way to avoid it. And that is what all these conferences and all these meetings and all these lectures I've been like obsessively watching this last month have said. Send them to endo. No, we cannot start your ortho until you go to endo. Endo is especially for all things root resorption, root damage, root everything, okay? So impactions that cause root resorption, whatever. Potential issues with impactions, endo, okay? Whether you like them or not. So I don't care if you do your own endo, you still have to send them to endo, okay? And yes, it might cost them something, and yes, you might lose that start, so be it. Oh well, too bad. Again, I'll tell you again, 99% of the time, this stuff doesn't happen if you do phase 1 interceptive, because this rarely happens with front teeth and just fixing bites. And if you do your phase 1 interceptive properly, this shouldn't be happening in phase 2. And so that's why I love phase 1 interceptive, and I'll keep saying it because it's so much easier, even though you guys worry about compliance, which really is not a big deal in little kids. Just pick your parents wisely, pick your kids wisely. And if you don't feel connected to them, don't take them. Send them to someone else. It's someone else's gift, not your problem, especially with little kids. Okay, so first of all, find things that might or may have happened before. Point them out, send them to specialists if needed, okay? This is part of the problem. You better take a pano. If you don't take pano, you miss a lot of stuff, you know? And if you miss a lot of stuff because you don't have a pano machine, not my problem. It's your problem. Again, if the average dentist who does ortho has a pano machine or has access to a pano machine, and if it's kind of not really recommended to do ortho without a pano machine or access to a pano machine, you probably shouldn't be doing ortho without taking a pano on a patient. Yeah, you can take an FMX because ClearCorrect and Invisalign allow it, but you might miss stuff. And if you miss stuff and it causes trouble, it's your butt. It's not my butt. It's not their butt. It's your butt. No one else's butt but yours, because you didn't do what you probably should have done, which is take a pano. Okay? So that's the main thing. And then, of course, progress x-rays. What do I tell you guys? Progress x-rays every year, no matter what. I don't care if this is your general patient. I don't care if it costs you money. I don't care. You have to take a progress x-ray. Should be a pano. Can you take an FMX? Yeah. But if you miss something, it's your problem. So, your risk. No, you can't charge them from progress x-rays. And yes, if the treatment runs 2, 3, 4 years, you're taking a lot of progress x-rays. No, you can't charge them. It's part of ortho. Okay? If you're able to loop that into the general and you're doing the general, great. If you're able to get the general dentist to give you the panel, great. But you still have to take it. You still have to find a way. And no, you can't access additional fees during ortho treatment for that. So plan this if you're going to do it. Okay, progress x-rays. And if there's a risk to something, like something is iffy or something's close to something or something's developing and might damage something, you better take way more than once a year. You have to put your pop-ups in your chart to take them at a regular interval, which normally is every 3 to 4 months. That's standard of care. Again, who makes the standard of care? I went over that in the last, or one of the previous videos. It's made, it's not published. So you need to ask people, what is standard of care in this situation? And I'm telling you, probably taking progress x-rays, whether it be PAs. I don't know about a CBCT every 3 to 4 months. That's a lot of radiation. Go back to your progress x-rays, your basic slob rule, your PAs with a shift. It's not hard. Learn to take an occlusal x-ray again. It's not hard. If you don't have the components, get them before you do ortho. Remember, if you're taking CBCT, you're responsible for everything in the field. It's not my job. It's your job. Or you have to pay somebody to read everything in the field that got picked up. If you miss something, it's your butt. You have to warn your parents of potential root resorption, or your patients, if you think things might happen before they happen. So the idea is to warn them about things you think even have a small potential of happening, and then monitor them so that you don't surprise them and be like, oops, this happened. Because again, if it's oops, this happened, it's on you because you didn't warn them. And anything you do, warning must be documented in writing, and even better, if you didn't just put it in your charts, if you wrote it in the treatment plan, which I told you guys at the beginning how to do a treatment plan, and they sign for it. And of course, if you sent them to endo, you should have a copy of the report from endo, not just I sent them to endo. No, you need a copy of the report. Endo should release you and clear you in writing. Yes, patient may start orthodontics, sign, signature, doctor's name. I know it's a hassle. Trust me, I do this stuff all the time, and a lot of patients will not start. I don't care. You don't want them to start then. If they're not willing to do everything that they need to do, but they'll be really happy to go follow an ambulance chaser and sue you, because I see this happening more and more and more and more than it ever happened. There used to be a lot of respect towards dentists. Now dentists don't have the same respect. Some specialists do, but general dentists, I'm sorry, you don't. So it's not the same esteemed profession it was when I started, which is part of the reason why I don't mind doing consulting, because, you know, if people aren't going to respect all the work I put into doing this and what my opinion is, then why do I want to do this? So, not to discourage you guys, but I'm trying to teach you guys how to do things better and best so that you will have the respect from patients. Okay, so progress x-rays, more x-rays as needed if there's a risk. You've got your regular informed consent, which has like basic stuff, but if there's like a risk, you better write your own supplemental. And no, this stuff doesn't exist. You have to customize it. Yeah, you can ask ChatGPT for help, but you better customize it and think about it first. You can also ask your liability insurance for more tips. They may have some stock stuff. I have a little bit of stuff that exists, but you have to customize this for this patient specifically. So I'm not going to write you an informed consent. It's not my job. I'm not a lawyer, but I'll tell you what things would bother me and you can put it in, but it's your job to understand this. And it has to be in their language. The informed consent, have it translated or have someone officially translate it. I know, what a pain in the butt. All right, what else? Mention the risk. Any risk must be documented in writing and patient needs to sign. Mention it throughout treatment, every single appointment. If you have like an issue or a risk, I would be revisiting that at least on the frequency that I'm taking progress x-rays every 3 months. You know, I used to have like pop-ups. Before I had pop-ups in charts, I had stickers. And they were like red stickers. And you couldn't put stuff on the front of the chart because of HIPAA, right? Unless if it was obvious, but you could put things inside the chart. So I had like certain colors for certain things. And the idea was that way, at least when I pull the progress notes out, I know if I see a red dot, it means risk of root resorption. I see this dot, it means this. That's how I did this back in the 90s, the 2000s. Now you got pop-ups, you got all kind of codes you can put in, you can build your own codes. Make sure you know all the risks for every patient. And to be honest, one of the beauty things about, I don't know, some of my strengths is that I could, by the time I saw patients, I knew, you know, so-and-so had perio and this. So-and-so had root resorption and this. Most patients are going to have some type of risk. It happens, especially if you're taking adults and older teens. If you're taking phase 1 interceptive, your only issue is probably going to be myo and habits, which is much easier to deal with. Because you know what? You don't start that case until the myo and habits are fixed. So, or ENT. So much easier, right? Keep mentioning it, keep documenting it every time you mention it. I know charting can be a lot of work. You can use HIPAA compliant charting programs to do it, but you can ask ChatGPT to help you, but you can't put patient information in that because that's not HIPAA compliant. And the worst possible thing is to have another dentist catch it. If another dentist catch it, either be it their general dentist, if you're not the GP on this case, or another dentist they go to a second opinion, you're toast if this happens. You better catch it first, and you better manage it first, and go over all the things that I said before. If you caught it on the early side and you had already flagged it, warned them, documented, they'd signed, they risked, you're good. I mean, they may try to store stuff up, but they're not going to be able to proceed with that. Or if they do, it's going to be almost nothing. So, as long as you catch it and you don't keep going, so many doctors I work with, when we catch little things, they want to keep going. I'm like, you pull the braces off. You put them in retainers if needed. You send them to the specialist. You can always put them back on. You stop the Invisalign retreatment. You don't wear aligners. I mean, obviously it depends on the situation. And you send them to the specialist if needed. We can always restart it. Be prepared. Anytime you start braces, you need to be prepared to take them off. And no, you really can't charge them again, because if they had a risk or something like this happening that isn't their fault, it isn't your fault, it's on you. That's just part of medicine. That's just part of dentistry. You might have to take the braces. Yeah, you may have to pay again. Now, if you built this into the treatment plan as a one-off, what would happen if this happened? Maybe you could. But, it can get a little messy with that. So I won't get into that. But yeah, we don't want another dentist to catch it. That's really bad. So again, thorough history, documenting everything, regular progress, good initial x-rays, good treatment plan that's signed and signed by the patient's parents as well, or patient if they're over 18, all that kind of stuff. Okay. So you inform the patient and parents if you catch something, or if there's a root resorption or root damage. You may have to stop. You may have to stabilize things. You may have to send them to endo. You may have to get a release from endo to continue again. You may have to take it out of occlusion. I have a ton of content on root resorption and impactions, and a whole section just on impacted canines. So feel free to look into that. But sometimes you just have to discontinue treatment. Yeah, you might have to give a partial refund. But again, these are things you need to build into your treatment plan. All the one-offs that might happen. Here's what's going to happen if this happens. Here's going to happen, that happens. And yeah, you might not get that start. Again, I'll tell you again, phase 1 interceptive is way easier. So I think that's pretty much it. And yeah, if there's an issue, when you start or even during treatment, and you can always redo treatment plans. If something comes up during treatment, endo says, you can keep going, redo the treatment plan now. Redo it. Redo your PAR question mark. Redo your RBA question mark. Redo all that, right? Do it all over again. Written diagnosis, written treatment plan, informed consent, supplemental informed consent. They all exist. You have to